segue into my talk, all the different therapies, where we're going in the future for breast cancer, both for men and women. I'm going to be talking about, apologies, some of you may have heard bits and pieces of this before for those who know me and have been with male breast cancer groups from the very beginning. So the title of my talk is Liquid Biopsies, and I'll explain what that is to guide cancer therapies for breast cancer. I had a subtitle before that the breast is yet to come, but I decided to remove that because I wasn't sure about the audience here today. These are my disclosures. By the way, I am going to have to add, I will be a consultant for AZ come December because I will be at San Antonio and doing a advisory board for Dr. Meyer's company. So I'm going to talk a little bit about kind of newer technologies, as Dr. Meyer said, and specifically about what is cell-free DNA or ctDNA, and I'll explain what those terms are. Really, Ingrid really set the stage nicely, so I'm not going to go over a lot about how we think about breast cancer and what the goals of therapy are, and really what are the unmet needs for early stage versus metastatic breast cancer in terms of how we treat it. And then hopefully you'll learn about circulating tumor DNA and how we're trying to use this to guide therapies better in breast oncology. So again, I'm not going to belabor these facts. You've probably heard them ad nauseum by now, but there's close to 300,000 cases in the United States. In fact, it may be 300 now. About 1% of all breast cancer cases are going to be diagnosed as male breast cancer. And even though that's a staggering number in terms of absolute number of breast cancers, and 1% is still a significant number because of that denominator, the majority of patients with breast cancer, in fact, will be cured. But because it's so common, we anticipate at least 40,000 patients a year in this country alone will actually die from their disease. So when I see a patient for the first time, I always talk about goals of therapy. Early stage breast cancer, that's 1, 2, and 3, is curable. Metastatic breast cancer, stage 4, is not curable. But as you heard, can actually be treated and quite effectively. In some cases, more and more often, we're seeing this becoming a chronic disease, similar to what insulin has done for diabetes. And I would actually even say with some certainty that there are some subsets of patients that truly have metastatic disease that are cured. It doesn't happen often, but when it does, it tends to be in the HER2 population because of the amazing drugs that we now have that you just heard about. So again, the goals of systemic therapies, metastatic disease, is to really prolong life and treat symptoms. What Dr. Meyer and I do as medical oncologists, we are systemic therapy doctors, or adjuvant therapy doctors, as we're sometimes called. We give additional drugs after surgery usually, but now, and we're going to talk about that a little bit more before surgery, as you heard, to really eliminate micrometastatic disease and improve on the cure rate. So what I mean by that, when you think about stage 1, 2, and 3, they're listed in that order because the higher the number, the more tumor cells you have in the body. And therefore, the more difficult it is to cure. And that's because it's not really a function of the local disease, because that usually gets removed by surgery and or with radiation. It's really the function of if you have more cells in your body that are cancerous, then there's a higher likelihood that some of those cells have already broken off and are setting up shop, if you will, in the body. And so we have to make decisions: who should get chemo, who should get endocrine therapy, who should get HER2-directed therapy, immunotherapy, et cetera. To give you some idea about the magnitude of this, in this country alone, every year, about 150,000, probably more now, patients are going to be candidates for these additional adjuvant therapies. Now, you may be asking, well, how do you make those decisions? How do you know if giving something works, since you can't see anything, right? This is micrometastatic disease, and by definition, that means we don't see it, and if we did, that would be stage 4 and incurable. And so the idea, or the proof of the pudding, really comes from decades of clinical trials where, and some of this you already heard from Dr. Meyer, if we have 2 groups of patients and we randomize them, and one group gets chemotherapy after surgery, which is in this light blue bar, and another one does not or gets placebo, we follow these patients out year after year, decade after decade, and we can see that the group that does chemotherapy has a less rate of recurrence and therefore also death from breast cancer than the control group. There used to be an old kind of online tool called Adjuvant Online that we used to demonstrate this to students and to patients. If you were to just take 100 patients, for example, then 63.1, if they just got surgery for their breast cancer, would be alive at 10 years, but about a third would actually die from their breast cancer, and about 4.3% would actually die from other causes. The absolute benefit in chemotherapy in this particular scenario is only about 12.6%, similar to here, which is about 13%. And that's shown here in the yellow. So that percentage seems relatively small, but if you think about, again, the number of breast cancer patients in this country every year, including male breast cancer, that means that we are saving or curing an additional tens of thousands of lives every year by giving these additional adjuvant therapies. I'd like to point out, though, to trainees that if you look very carefully, the blue bar is also slightly increased. And that is a known fact that chemotherapy and other therapies can have as a consequence death. And so we know that and accept the fact that overall we're doing far more good than harm, but there is harm. And that leads to the bullet points on the right. And, these are kind of the problems with our current paradigm, is that we tend to overtreat, and I'll show that in the next slide. And probably the biggest thing is, well, it also takes years to do these types of studies, or decades, but the biggest one is this last point. We don't know who's cured and who isn't. And so that's really the current problems for early stage breast cancer, whether you're a man or a woman. We have no idea when we see a patient and they do surgery or they get chemotherapy if they're cured or not. And in the adjuvant paradigm, this is what we see. We treat 100 people knowing that 63% don't need it, they're cured. But this is the yellow and the red. We don't know who's actually benefiting, and we don't know, even if you get chemo and you need it, that it doesn't work. And so that's kind of the crux of the problem that we're trying to address with what we call liquid biopsies. So measuring microscopic tumor burden by liquid biopsies, we hope, will be the answer. And so these are blood tests that we will, in the future, we hope, will inform clinical management for breast cancer decision-making. Our approach has been to use something called circulating plasma tumor DNA, or ctDNA, sometimes nowadays just circulating tumor DNA, as a marker of micrometastatic disease. And the principle of this is very simple and elegant, in that cancer is a disease of DNA mistakes. And so if we see DNA mistakes in the blood, that's from the cancer. And that's a very simplistic overview, but that's the gist of it. The idea in the future would be, if a patient has breast cancer, as denoted by this black dot, after surgery, if that patient falls in the majority of patients that are cured, and that, using the prior example, 63.1%, that patient is no longer going to be ctDNA positive, they'll be negative. On the other hand, if they still have microscopic disease, they will still be ctDNA positive. It will be a lot less than the pre-surgery, but it'll still be there. And the cool thing about this is, if you think about it, when you give the chemotherapy, now we can take repeat blood measurements and see whether or not that level goes down, i.e. that patient ends up being cured or not. Now, I've been talking about ctDNA, or cell-free DNA. What is it? If you look on the picture on the right, this is a cartoon really showing that there are cancer cells in the blue, there are normal cells in the green. And it turns out, for decades, we have known that all cells will secrete out free-floating naked DNA into the bloodstream and the circulation. What this does, or what's the purpose of this, nobody really knows. Most people think that this is just cellular waste. I've been known to call it cellular poop, because that's kind of what it is. And then it just goes out into the kidneys and gets excreted in the urine. Has a very short half-life. But as I said in this cartoon, you can see that the normal cells are secreting normal DNA, and they're all uniformly green. Cancer cells have all these mistakes in their DNA, mutations, fusions, etc. And so those are in various colors here, and are all going to be shed into the DNA as well. Unlike what this picture shows, though, really the vast majority of cell-free DNA is normal DNA. Because think about, we have trillions of cells in our bodies, and even with high cancer burden, it's still going to be a smaller relative proportion. And so this used to be, we called it the proverbial needle in the haystack. That's why, even though we knew about this for decades, we really couldn't do anything about it, because we didn't have tools and technology to pluck out and analyze just the circulating tumor DNA from the rest of the normal cell-free DNA. And so the first technology came from Johns Hopkins, where I used to be for 20 years, from my old boss, Bert Vogelstein, and it was a technique called digital PCR. This is literally now probably almost 20 years old technology, but it was really the first proof of principle concept that you could do this. Now, I think most of you probably know this, Where's Waldo, and this is the analogy I like to use. If you thought that this was a drop of blood, and that every single person in this picture is a strand of DNA, And that in this particular case, we're only interested in the people with the horizontal red and white shirts. Those would be a gene, let's say, or a specific piece of DNA. And moreover, we want to get down to the weeds and say, hey, which one of those are mutated, or are there any? And so that would be Waldo in the Where's Waldo analogy. So what digital PCR and what we now, its next evolution of next-gen sequencing does, it very quickly will isolate individual fragments of DNA, amplify it, and then you can analyze it. And so that's shown here. You isolate and amplify, isolate and amplify. And if you do that fast enough, massively in parallel, you can see Waldo, or the mutation of the DNA in that case. So we were one of the first to partner with various companies, including Bio-Rad and Raindance, with a newer technique called droplet digital PCR for ctDNA detection. It's a pretty cool yet simplistic technology. You just have these microfluidics that bleb off these bubbles, and each of these bubbles will isolate a single strand of DNA, and then you can do something called polymerase chain reactions with fluorescent markers for mutant versus wild type DNA, and then you just do read them on a machine. We did an initial proof of pilot study, or proof of principle pilot study. This is again back at Hopkins, and it's been published and is more than 10 years old now, so I'm not going to belabor this, but these were early stage breast cancer patients. We were going to do 30 patients. We ended up having one patient with 2 breast tumors, so ended up having only 29 patients, but 30 breast primaries. And then we got bloods both before surgery and then after surgery. And we simply asked, hey, could we actually detect these mutations in the blood the same way we could detect them in the tumor? Again, I'm not going to belabor this. In this early analysis, all we did was look for 2 common mutations in a gene called PIK3CA. Some of you may have heard this gene now because this is a gene my lab actually helped discover in breast cancer many, many years ago, but now we have this drug called alpelisib that you can get if you have one of these mutations. But we did old-fashioned sequencing on the tumor tissues, and everywhere you see these purple letters is where you see one of the 2 mutations. When we use this newer technology on those same tissues, we actually ended up picking up 5 more mutations shown in the green. And that was not unsurprising because we knew that the sensitivity of the old-fashioned way was you had to have at least 20% mutation fraction. And again, if you look at the green ones, for the most part, they are less than 20%. It's interesting that this one was not, and we still never figured out why it wasn't in the regular sequencing. But then when we looked at the pre-surgery blood, asking the question, if they haven't had surgery yet, can we still pick up the mutation in the blood? It turns out for the most part we could, except for as luck or bad luck would have it, is number 13. We've missed one, and that was pretty amazing that we could do that. We got bloods post-operatively. Hopkins, like Vanderbilt, is a big referral center, so we couldn't time the post-op bloods. Many patients don't come back. They just get their surgery at academic medical centers, and then they go back home and get their additional adjuvant therapies. So whenever we could, we got them back. These were the patients that had mutations, so they were informative of the whole 29 patients. And the ones in the red are ones that had persistent DNA mutations even after surgery. Now, again, some of these patients did not get their endocrine therapies, their radiation, et cetera, when we took this. So it wasn't like they completed all of their therapy. But there were a couple examples of 2 triple-negative breast cancer patients. You heard from Dr. Meyer that those are the more aggressive ones. And here in patient 5, that patient ended up having clearance post-surgery and until 2017, in fact, now 2023, because I have looked at these, still is disease-free. On the other hand, this patient, number 16, had a very high rate, 2.99% or 3% is actually considered fairly high, pre-surgery. Ended up actually getting delays in her surgery for a number of reasons. And as a result, did get complete scans up and down her body, which is something we don't generally do. And she was negative, and so then she started her chemotherapy. And we ended up getting her chemotherapy or her blood sample even during her chemotherapy. As you can see here, day 85 versus day 65 is when she started. And unfortunately, she ended up developing recurrent disease and ultimately succumbed to her disease. So this was really, again, an early pilot suggesting that you could use circulating tumor DNA to address the question that Rick asked. Maybe you could actually see it before widespread metastasis develops. This is a summary of that whole study. Again, this has been published, so I'm not going to belabor this, but suffice it to say, this was really exciting for us and really the first proof of principle for early stage breast cancer. I think the potential impact is obvious from the stuff I already mentioned. This is something that hopefully we could just figure out who's cured and who's not. And maybe we don't have to treat everyone with every single modality of therapy, which is something we currently do depending on stage. And that would really individualize care or treatment plans for every patient. I think also we may be able to use this to get drugs approved faster, rather than waiting decades to see who recurs and who doesn't. If we have a molecular marker of recurrence, a surrogate marker, that may be good enough from the FDA standpoint to say that patients who molecularly recur versus those that don't is a good enough way to get drugs approved. All right, and some newer data. This is not my data, but something I discussed at our big oncology meeting called ASCO last year. And I love this because Heather Parsons, who's the senior corresponding author, was in fact a trainee in my lab at Johns Hopkins, and now she's at Dana-Farber Cancer Institute. Her trainee, Dr. Lipstick Sharp, was actually the first author of this. And so we all made the joke at that meeting that her trainee was in fact my scientific granddaughter, which makes me feel older than I already am. But in this study, what they did at Dana-Farber is they had this whole collection of blood samples from patients who were hormone receptor positive, HER2 negative, and they just kept following them out year after year, decade after decade. And this is the title of their abstract that has now been published as well. And what they showed was of 83 patients, they had 8. And now these are women, again, with long-term follow-up, still taking endocrine therapy in some examples, and they had 8 had detectable ctDNA. 6 of those patients ended up eventually developing metastatic disease. And then the median time for that was about a year, meaning the median time that they detected it between the time they clinically presented with metastatic recurrence. 1 out of 83 actually also had recurrence, but it was not far spread metastatic disease, but what we call local regional recurrence. And some of those patients are still curable. And then 2 out of 83 still have not recurred. Probably my guess would be that they will at some point, as sad as that is to say. But that's really where we have an opportunity as a clinical research study to make interventions. And so, this is very provocative, small sample size, 83 patients, and only 8 had positive ctDNA. But as I said, you can imagine now a study design where if you are ctDNA positive after all standard of care therapies, you could get, these are patients who traditionally would never have gotten the CDK4/6 inhibitors. Now you can get that if you're a high enough stage or high enough risk. And so we could potentially give this group of patients that therapy that's already FDA approved and see whether or not that ctDNA goes down and maybe cure a lot more patients. All right, you heard Dr. Meyer talk about neoadjuvant chemotherapy. These are situations, particularly for HER2 positive and triple negative breast cancers, where we give chemotherapy up front. And as you heard, the goal really is to get what we call a pathologic complete response, or PCR. And nowadays, about 50 to 60% of these patients will, in fact, achieve a pathologic complete response. And as she mentioned, that's a good prognostic marker. You can imagine why that is, though, right? If you go get all your therapy up front, then you get surgery, and then at the time of surgery, there's no tumor left in the axilla as well as the breast. You pretty much destroyed every cancer cell in the local regional space. And if you have that good of a response systemically, you probably will also have as good a response systemic, or if there's micrometastatic disease. So this is actually a surrogate endpoint for faster drug approval. And we have 2 drugs that have so far been kind of approved that way: pertuzumab for HER2 positive disease and pembrolizumab for immunotherapy and triple negative disease. And as was mentioned, even though there are situations, the 40 to 50% of patients who don't achieve pathologic complete response, we can then change therapies after surgery to affect a higher rate of cure. So even though it's not as good to not have a pathologic complete response, all is not lost. And we continue to do more in this space for research, including using ctDNA to see if that can help guide us who's at the highest risk. I'm part of a study right now where we're in fact doing that. If they have pathologic residual, or if they have residual disease, meaning they didn't get a pathologic complete response, and they're ctDNA positive, we're actually giving those patients additional therapies on research study and they wouldn't be able to get that otherwise. So our shtick in this is very exciting, but I always take a half step back here and remind everyone, as exciting as this is, we still have to really prove that this has utility. There are companies right now today that breast cancer patients, colon cancer patients, they can get a test and the company will say whether you're ctDNA positive or not afterwards. I think that's a little bit premature and a little bit dangerous because we don't actually know whether or not, if you're ctDNA positive, what to do with that. We probably do know, because this is what is called clinically validated or clinical validation. We probably do know if one is ctDNA positive after all your early stage breast cancer therapies, that's not a good thing. Again, all those studies that I just pointed to really speak to that. What we don't know is what to do with that information, and that's where we need research, meaning that if your ctDNA is positive after surgery and chemotherapy, does giving you more therapy cure you? Those types of studies still need to be done before we can really say what is the utility of ctDNA in this early stage space. Moreover, the negative predictive value of all of these commercial tests that are available right now is not very good. And what I mean by that is just because your test is negative does not mean you're cured or free of cancer. So that's a big problem. And most of the times companies don't explain that to patients. Most of the times doctors don't know this. And so they're not going to be able to explain it to patients because they don't know what the NPV is. That's a real problem with our business right now. And I'm a big believer of the quote from a godfather in the biomarker field, Dan Hayes, who says a bad test can be just as dangerous as a bad drug. And I really do believe that. And so this is why we still got to do these types of studies to prove clinical utility. All right, so I'll stop preaching and I'll tell you what we've done after the pilot study. This is a study in the neoadjuvant space, HER2 positive, triple negative breast cancer. They all get chemotherapy up front. And the idea here would be that if they achieve a pathologic complete response, they're probably cured, right? But how do you know that unless you do surgery? And so the idea in this study is let's see whether or not our markers are as good as they are, and they can actually predict for pathologic complete response. And in the future, you could offer a patient a no surgery option. When I first presented this concept, geez, about 7, 8, or 9 years ago, all the surgeons in the room thought I was absolutely crazy. But if you think about it, when you do surgery or you receive surgery and you have a pathologic complete response, you haven't done anything therapeutically because you just removed healthy tissue. All the cancer cells are dead. The catch-22, of course, is you don't know that till you do the surgery. So if we could use liquid biopsies to predict and correlate and say, hey, you have pathologic complete response by a liquid biopsy, that might be a way that we could offer that. This is the title of the study, Pathologic Response Evaluation and Detection in Circulating Tumor DNA. It took me hours to come up with this acronym, and I'm very proud of it because in clinical trials world, they just pick a letter from each word to make some. This one, it's the first letter of every word, maybe except with and. I cheated on that one. But yeah, so for me, and this was, again, well worth the hours that I spent on it. I'm just kidding there, by the way. So if you look at this, stage 2 to 3 breast cancers, getting tissue, getting bloods at various time points, and we're defining what I call a liquid pathologic complete response so that we could potentially avoid surgery. Again, the idea here is that if it's positive before chemotherapy, but then negative, that will predict for pathologic complete response at surgery. Probably the more important endpoints, I think, long-term, though, are getting all these blood samples. Remember, these are all those standard of care or after standard of care blood samples. And what we're going to try to see is whether a negative result is equatable to a cure. And then if it's a positive result, is that actually going to lead to worse outcomes, which we predict now from all the other studies that it likely would. The hope is that, again, we can still take some of those patients and put them into clinical trials. So this has now been done for at least 5 years. We have all the samples now at Vanderbilt, and we're getting ready to analyze them. And we're going to close the study except for the analysis at most of the sites. But we have a probably median of about 5 years of follow-up now in this particular study, if not more. Getting back to pathologic complete response, you may have remembered Dr. Meyer said that maybe 5 or 10% of patients, despite pathologic complete response, are still going to recur. This is another opportunity. We did an early pilot study with these data and these samples, and we found 3 patients, this was only out of, I think, 30, that actually had pathologic complete response, but in fact still were ctDNA positive. We're still following these patients. It's blinded, so I don't know who these patients are, but my guess is they've probably recurred, and unfortunately are those unlucky few that despite having pathologic complete response, in fact, are probably still going to have residual disease. And why is this? I mentioned that the negative predictive value, or NPV, here is not that good for current commercial assays. I think one has to think about what the mathematics of this are, what the problems are. And it's really about taking shots on goal, or taking enough shots on goal. If we think about, again, normal cells versus cancer cells, and that they're secreting all their DNA into the bloodstream, here the cancer cells have these mutations, and you can see those in the red bars with the different colored stars representing mutations. The shtick nowadays is, okay, if you can't get enough blood, that was our strategy. Let's get enough blood, and we looked at one or two samples. So if we looked at just the red and the yellow star in this kind of diagram analogy, and those were our markers, we would then kind of try to look as get enough blood as possible, and then the red and yellow stars should be in there. On the other hand, if you were only to look at the red and yellow stars and you took a smaller amount of blood, you're going to miss it, as depicted here. And so the shtick nowadays is, let's look at a lot of different markers. And if we only have a little bit of blood, we should find at least one. So it's kind of flipping it up on its ear. And that's what you're seeing here. If you looked at all the stars in this particular small volume, you still have a green star. So you find that there's cancer DNA, and you know that patient has some sort of cancer in their body. All right, there are newer technologies coming to bear, and so methylated DNA, it turns out our DNA is not just bases of the alphabet of DNA, A, T, C, and G. There's all sorts of modifications that are hooked up on DNA, including methylation. And so methyl groups are just these carbon hydrogen groups that stick onto DNA. And it turns out that DNA's methylation is different than normal cells. This has been known for decades, but we didn't really have sensitive, good technologies to detect this in cell-free DNA until now. And so I'm not going to go over and belabor all these different older techniques, but newer techniques have really been surprisingly good. And so I was part of this study. This is from a company that's looking at using cell-free DNA, not as a, although they will be doing this, but early on, not as a detection test for residual disease, but as an upfront screening test for cancers. And so what they did was they took all these patients who had cancer, stage 1 to stage 4, across all these different cancer types versus normal controls. And they said, can we detect these cancers with our new technologies of cell-free methylated DNA? And surprisingly, these are area under the curve, so those who are familiar with it, it was pretty darn good across all different types of cancers in all stages, including breast cancer. I'm not sure you can read those tiny numbers, but this is something that's hugely promising and doesn't require as much blood because of the way they're capturing that DNA, something we call immunoprecipitation. So other companies are also catching on to this. Time will tell, but this may also be the future of not only using a blood test to detect cancer, but also using a blood test to detect whether you're still have cancer or are cured after curative intent therapies. All right, I'm going to shift gears here now and talk about metastatic disease. So again, not curable, but treatable. And one of the things that we do use liquid biopsies for routinely nowadays is to see whether or not there are mutations that we have drugs for. I mentioned PIK3CA and alpelisib. So that's using the qualitative aspects. One of the things we don't do or haven't done yet, because we haven't done studies, is to use the quantitative aspects of ctDNA. And what do I mean by that? I think for those of you who know people with metastatic disease or have this yourself, you know that you get a therapy, you wait 3 months on average, and then you get a repeat scan and see whether it works or not. And it's great if it does work or it's stable. It's not so great if it didn't work and you feel like you've just wasted 3 months of your life on ineffective therapies. And that's kind of the challenge, but that's the idea. Could we do better? So this was a study that I was involved with when I was at Johns Hopkins called IMAGE. Essentially, we were just correlating in metastatic triple-negative breast cancer patients a tumor biopsy with liquid biopsy. Very pedestrian by today's standards, but again, this was almost a decade ago and really was the first of its kind when we did it. But one of the things we also did with the ctDNA is get serial samples, and I'll point your attention to patient number 3. This was a young woman who had metastatic triple-negative breast cancer with a big metastasis in her brain. And this was her baseline. So when she entered the study, she had a very high frequency of, back then we called it plasma tumor DNA. And then she got the lesion resected from her brain and it dropped dramatically. Unfortunately, she did end up progressing, and that's shown here, and ultimately succumbed to her disease. But again, really good correlation. And other now people have now shown this. So, we right now have a lot of drugs for breast cancer, but even with triple negative breast cancer, when we used to just have chemotherapy, as you just heard, we have now antibody drug conjugates, we have immunotherapy, et cetera. And the idea came to us, can we actually do better with the paradigm, the current paradigm of just treat, wait 3 months, and then rinse and repeat, so to speak. And Dr. Meyer mentioned this, but generally speaking, if you have a drug that works really well in second and third line metastatic disease, it's going to work even better in first line disease and even better in early stage. Why is that? It's really about clonal heterogeneity, as we call it. This is kind of what we're dealing with. When cancer cells divide, they're all a little bit different from one another. And so even though we get a great drug, if we don't kill off everything, as denoted here in this little yellow cells, that's what we call a bottleneck or a clonal bottleneck. And then that just begets more heterogeneity as those cells divide. Pretty much if you can detect a 1 centimeter cancer somewhere in the body, that's already 1 billion cells. And that's why we can't cure overt metastatic disease. There's just too many different clones. And but this is also why first-line therapy is going to work better than second-line therapy. Dr. Meyer mentioned a drug called Trodelvy, which some of you probably have heard about. It's also known as sacituzumab govitecan, and it's an antibody drug conjugate. This was approved for second and third line patients in metastatic triple negative breast cancer. It's now also approved, as you heard, for hormone receptor positive HER2 negative disease, and pretty impressive improvements in progression-free survival and overall survival, as well as objective response rates. It was studied and still is only approved in second and third line therapy for these patients. And it's fairly well tolerated. And this is what we mean by an antibody drug conjugate. The antibody portion is the green bar. That's a protein. It recognizes the cell surface receptor TROP2. And it's a Trojan horse strategy. As you heard, it just allows this antibody to get inside the cell. Once inside the cell, all these little chemotherapy molecules get activated and they blow up the cell from the inside out. So this is a very clever way to direct chemotherapy into cancer cells. So we have a trial that we just started, and this is a trial that is part of what we call our SPORE, Specialized Program of Research Excellence from the NCI. It's going to take triple negative breast cancer patients who are PD-L1 negative. That means they are not eligible for immunotherapy. That's about 60% of breast cancer patients with triple negative disease. And the first arm is just this is a randomized control trial, is just a normal standard care. They're just going to get their chemotherapy, and then they're going to get reassessed after a couple cycles. The second arm, or the arm B, is the intervention trial that we're going to do with circulating tumor DNA. We're going to get a baseline and then start chemotherapy. But right after, about 2 weeks after we start it, we're going to get another one. And then based upon the relative increase or decrease of the second blood draw to the first blood draw, tells us whether or not patients are responding or not. And so if they're responding, which the inflection point is less than 50%, we'll continue with the therapy. If they're not responding, we're going to change them to this drug sacituzumab. And we hope to see better responses on the first staging scan, better overall survival, better progression-free survival. It's really exciting because this is really the first time anyone's tried to use the quantitative aspects of ctDNA to guide therapies. All right, and so in conclusions, hopefully I've convinced you that ctDNA can in fact change the paradigm and rationale for how we could administer systemic therapies, not only for early stage breast cancer, but for also other solid tumors as well. This will allow in the future for truly individualized precision medicine. And as I mentioned earlier when I got up my soapbox, we really need the same level of high level of evidence that we require for drug approval, prospective randomized trials that demonstrate clinical utility. And with that, lots of people to thank both in the lab as well as collaborators and all of our funding agencies. And I'm happy to stop there and stop sharing my